Hi, this is Sonu Kami, and today in this video we will be going through Mr. John Forrest's case study and answering the three questions. Mr. John Forrest is a 57-year-old male who has a history of COPD, hypertension, and previously vein thrombosis. Firstly, I'll be describing the underlying pathophysiology of his condition and identifying the early and late warning sign. I believe Mr. Forrest is experiencing an acute exacerbation of COPD, likely triggered by a respiratory infection, given his prescription of Keflex, an antibiotic. During an exacerbation, inflammation worsens, causing swelling in the airway and increased mucus production. This further blocks airway, making it difficult for him to breathe, as seen with his rapid breathing of respiratory rate 33 beats per minute and low oxygen levels, saturation of 86% on 2 liter nasal prong. The infection also disrupts gas exchange in lungs, leading to hypoxia and potentially hypercapnia. Additionally, his body's response to low oxygen includes faster heart rate and increased blood pressure, which put extra strain on his heart. Without timely treatment, this could progress to respiratory failure. His early signs includes tachypnea, which indicates increased work of breathing, hypoxia, tachycardia, hypertension. He is sitting in a tripod position, which reflects respiratory distress. He has a fatigue, and he is also speaking in a broken sentences. His late warning signs, if untreated, include cyanosis, the discoloration of lips or skin, altered mental status, respiratory exhaustion, bradycardia, and hypotension. As body can no longer compensate, the heart slows down and the blood pressure drops, eventually leading to respiratory failure. Secondly, I'll be applying systematic person-centered approach to assess the sudden deterioration by going through the A to G assessment. Firstly, airway. To ensure the airway patency, check for secretion or obstruction and suction if required. Breathing, monitor respiratory effort and effectiveness like rate, rhythm, and use of accessory muscle. Reassess oxygen and titrate oxygen therapy as needed. Example, switching to venturi mask or non-breather if severe hypoxia persists. Circulation, monitor blood pressure, heart rate, capillary fill, and peripheral perfusions. Disability, access GCS and monitor for signs of altered consciousness or confusion due to hypoxia or hypercapnia. Exposure, check for fever or other signs of sepsis. Fluid, evaluate fluid status by monitoring urine output and checking for signs of fluid overload or dehydration, as he is on 1000 ml of IV fluid running. Glucose, check visual to rule out metabolic imbalances affecting respiratory functions. His immediate plan of care for deterioration include notifying the medical team immediately, active the rapid response, titrate oxygen if required to achieve saturation between 88 to 92%, which is the target range for COPD patient, via a non-rebreather mask to avoid worsening hypercapnia. Administer nebulized bronchodilators, example salbutamol to relieve bronchospasm. APG analysis, check for hypoxia, hypercapnia, respiratory acidosis to guide the interventions. Sit the patients upright to optimize lung expansion. Continue prescribed Keflex and obtain sputum culture if not already done. I'll be outlining the short-term nursing care and long-term nursing care. The short-term care includes most of the immediate plan of care, like notifying the staff, supplying the oxygen, like positioning and administering medication. I have also given the rationales. Moreover, we can also closely monitor Mr. Forrest, monitor his vital signs, respiratory assessment every 15 to 30 minutes during the acute phase. Encourage coughing techniques or use suction if secretion obstruct the airway. We can consider chest physiotherapy. We can reassure Mr. Forrest and explain each intervention clearly, update his family on his condition and care plan. Finally, the long-term nursing care includes smoking cessation. Provide support and resources to help Mr. Forrest quit smoking, for example, nicotine replacement theory, counseling, as cessation slows disease progression. We can encourage participations in programs focused on exercise and breathing techniques to optimize the lung functions. We can give him medication education, like teach correct use of inhalers, for example salbutamol, and ensure adherence to prescribed regimen, as proper use of medication includes reduce exacerbation and improve the symptom control. We can promote annual influenza and pneumococcal vaccines to reduce the risk of infections that can trigger exacerbation, and we can also arrange regular follow-ups with GP or respiratory specialists to optimize the COPD management. That's all. Thank you so much, guys.